40-year-old male presented with unintended weight gain, fatigability, tiredness, poor appetite, hair loss, and hoarse voice. Physical examination reveals a puffy face and periorbital edema and pedal edema. Okay, so at this point of time, right, you can think of either hypothyroidism or hypercortisolism, right? This picture can fit into Cushing's as well as hypothyroidism. But now when we further examine, we can see an enlargement of thyroid gland, and FNAC of the thyroid gland shows diffuse lymphocytic and plasma cell infiltration. Okay, so by now we clearly know what we're dealing is a patient with hypothyroidism and not hypercortisolism. Okay, now what is the most common cause for hypothyroidism? In iodine sufficient population, it is Hashimoto's thyroiditis. In iodine deficient population, it is iodine deficiency. Okay, so in this case, among the options, already in terms of statistical probability, I'm thinking more in favor of the Hashimoto's thyroiditis. Plus, when you tell that you're dealing with diffuse lymphocytic and plasma cell infiltration, which is again very typical of the Hashimoto, so I'm going ahead with the diagnosis of Hashimoto's thyroiditis. Can it be Graves' disease? No, in Graves' disease, the symptoms will be exactly opposite, right? Patient will have increased appetite, he will have weight loss, right? Then he can have the proximal myopathy, so tiredness can be there, but otherwise he will have weight loss, increased appetite, the fine resting tremors, anxiety spells. Those will be the typical story. That is not the case here, so it is not Graves' disease. Symptoms are very clearly supportive for the diagnosis of hypothyroidism and not hyper. Okay, can I make the diagnosis of lymphoma? No, right? Lymphoma can be only diagnosed with the biopsy feature suggestive of lymphoma. Here it is only showing that you have lymphocytic and plasma cell infiltration. No abnormal lymphocytes are noted, so I'm not going ahead with the diagnosis of lymphoma. Can this be de Quervain's thyroiditis, or what you call as subacute thyroiditis? The answer is no. Why? Okay, typically for most patients with the subacute thyroiditis, they will have a preceding respiratory infection, especially upper respiratory infection, right? Often they have history of preceding infection. Okay, then the second point going against the diagnosis of subacute thyroiditis is subacute thyroiditis progresses in phases. So you have an initial phase of thyrotoxicosis or hyperthyroidism, followed by hypothyroidism, and then you enter the euthyroidism, right? Thyrotoxicosis, because at this point of time, the thyroid is under inflammatory attack and it is leaking the thyroid hormone into blood. So you have thyrotoxicosis. Then patient enters into hypothyroid phase because the stored thyroid hormone is all leaked into circulation. The existing cells are under the inflammatory attack. They cannot synthesize any more hormone. So you enter into hypothyroidism. Then the cells will finally start regenerating and start bouncing back. And that is where you get the euthyroid state. This is a typical flow. I don't see that flow in this case, neither the history of preceding infection. So keeping that in mind, this is not de Quervain's thyroiditis, making option A the clear answer for this case. Now, the only one fact you might not have noticed which goes against the diagnosis of Hashimoto's thyroiditis here is male. It doesn't mean that males are never affected with Hashimoto's, but relatively less common. It is typically more common in females, right? So that's it from me here, guys. Thank you.